Very warm greetings, everyone, wherever you are. And today we are privileged to start a conversation around advanced care planning. What is in the pill? And what is in the pill simply means, what is it all about? What are the advantages? What are the disadvantages? What are the existing challenges? And where are we at with the conversation? And today I have two distinguished panelists. We have Dr. Nahala Jaffer, who is a clinical oncologist and has worked in the field of oncology for over 14 years in Sudan, specifically at Khartoum Oncology Hospital. And she specialized in breast cancer. And she volunteered to start up a palliative care service there. Nahala has had some of her education at the Institute of Hospice Africa, Uganda, and she's a pioneer who actually started a palliative care service in Sudan. And she has supported very many countries. Actually, Nahala, you give us all the courage to start up services and do whatever we can do to support patients from wherever they are. Nahala completed her fellowship in pain management at Winscon Pain and Policy Study Group. And she has been supporting several palliative care teams in training and finding opportunities for training overseas. And the team has formed a group of doctors, medical officers, palliative care nurses, psychologists, and volunteers. Nahala was also involved in the establishment of palliative care services in other parts of Sudan and also other parts of Africa. And she contributed to lots of training opportunities in the WHO EMRO region, for example, in Kuwait, in Mauritania, in Oman, Iraq, and Gaza. And she has received two accolades. One is the IDEA for palliative care that came from the ASCO Foundation, and then the title Visionary in Palliative Care from the American Academy of Hospice and Palliative Medicine. She's a member of IAHPC and a distinguished researcher. Right now, she's looking at early integration of palliative care into oncology. And this project is going to see her win her PhD in palliative care and rehabilitation from King's College, London. And Nahala is currently serving as part of the expert network for palliative care in the Eastern Mediterranean region. We usually call that the EMRO region. And she's a lovely mother of two young boys. And she lives in Cairo with the young boys because of the war that we know that disorganized livelihoods in Sudan. And then our next panelist hails from Mozambique, and this is Lane Hiller, and she's a second-year palliative care doctorate student at the University of Maryland in Baltimore, America. She has a master's degree in palliative care from the same university, and she's a co-founder of Casa Ahava. And this is a hospice home that is based in Maputo, Mozambique, where she has been working for the past 14 years. And her interests include understanding, creating, and implementing palliative care in an African context. So besides those two panelists, my name is Eve Namisango, and I'm the Programs and Research Manager at the African Palliative Care Association. My research interests include end-of-life care, advanced disease, and then the role of art, culture, values, beliefs, gender, and social norms in shaping care, especially in advanced disease. So I'm briefly going to tell you how we are going to run this webinar. In a second, I'm going to share my slides. And in the meantime, feel very welcome for the session. And I'll give a few housekeeping rules as I prepare to share the slides. We are going to have the speakers present, and then we are going to spend some few minutes responding to questions and answers and having contributions from anybody attending this webinar. We are keen to have experiences from Africa and beyond. And I'm indeed delighted to set the stage, advanced care planning, what is in the pill. So we are going to talk about advanced care planning, what it is and why it matters. Then I'll briefly touch the issues of law, ethics, and care, where the intersection is and the implications for practice. And then my colleagues Nahla and Leng will talk about the current practices, challenges, where we are as a region, and our priorities. So we'll start by defining advanced care planning. And I have a definition that emerged from a Delphi process, a highly rigorous consultative process. And it's agreeable that it's a process that supports adults at any age or disease of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. And the goal is to ensure that people receive medical care that aligns with their goals and preferences during serious and chronic illnesses. And for many people, this process will include choosing another trusted person or people to make medical decisions on their behalf if they are no longer able to make their own decisions. And then Suderi et al. Wrote a paper in 2018, and they highlighted some of the benefits of advanced care planning. First of all, they noted that the benefits are at patient level, surrogate family level, clinician level, and health systems level. And I'll now focus on some of the outcomes that patients receive care that is consistent with their goals. There is satisfaction with care, there is the engagement in decision-making and informed communication. And then when people have better health status, mental health status, their care utilization also reduces. So at whatever level, whether you're a patient, family clinician, or health system commissioner, all of us can benefit from advanced care planning. And here are some of the 10 recognized benefits of advanced care planning still: receiving care that is consistent with goals and values, giving patients an opportunity to decide on their surrogate, to document this decision maker and keep yourself out of trouble, and then giving patients an opportunity to talk about their preferences with their surrogate. And the 10, you will read about them when I share the slides. And in my work with bereaved caregivers, they indeed attested that advanced care planning, if offered, is associated with positive grief and bereavement outcomes. People have closure and they are satisfied with the process and outcomes, and that leaves them better people, and they are more empowered to handle the grief and bereavement journey. And this is the case study of Uganda. This work was led by Dr. Guma and a co-author on this, as well as Dr. Henry Dungu. And the study aimed to identify the extent to which advanced care planning is practiced by healthcare professionals in Uganda. And in this study, Guma noted that of the 57 health professionals who participated in the survey, 87% were aware of advanced care planning, but only 1.2% were practicing. And the key message here is that despite the awareness and the good attitude toward advanced care planning, the practice was very poor, and a range of barriers were identified in that study. And from that, we concluded that there is need for development of a legal framework for advanced care planning and more research to understand the contextual barriers and to offer appropriate education and public sensitization programs on this issue. And then this work was led by Basirika, Professor Merriman, still Dr. Sam Guma, and several others. And it's a survey that we undertook in Africa, where 47 palliative care providers responded. And of these, 40% had cared for patients with advanced care plans, and 19% did not know whether their patients had advanced care plans. And we see that that has implications at all the other levels we talked about: patient level, family level, health facility level, and government level. And the respondents in that Afro survey noted that they would respect the patient's advanced care plan. And also 86% had never completed an advanced care plan form for themselves, but they were willing to respect an advanced care plan if one was available. And the key message here is that there is some level of awareness and there is some willingness, but why aren't we practicing advanced care planning? This is the elephant in the room. And one of the things that have come out strongly is the risk of legal issues. We know that constitutions override anything, and we know that there is an overlap between the laws, the ethics, and advanced care planning. And we also noted among facilitators and barriers that knowledge was important. So we cannot undermine the issue of knowledge, but we must also tackle that monster, which has to do with legal implications when it comes to advanced care planning. And I'll point out some of the existing frameworks in Uganda which one can use to advance the advanced care planning agenda. One of them is the Patient Rights Charter, which sits with the Ministry of Health. And that one clearly emphasizes the right to refuse treatment, that a patient can refuse treatment after receiving sufficient information to make an informed decision. But the question would be, what is sufficient information and what is an informed decision? And such a refusal can be verbal, in writing, and one must not endanger the health of others as they sign up to refuse. So these are some of the frameworks and statements that can help us support people to advance advanced care planning. And I'm not going to read this whole 1.2 statement on refusal, but that refusal can be declined if there is need to protect an unborn, a minor, or a disadvantaged person, or if you're going to be a danger to society, that wish may not be respected. And then I'll also just point out the Constitution of Uganda, and this is supreme law, and Article 22 of the Constitution reaffirms an individual's right to life to the extent that no one should be intentionally deprived of the right to live. And we notice that at times these advanced care directives can bring in controversial issues, and one may find themselves on the left side of the law. And then I will say that we have some open resources. The African Palliative Care Association, Palliative Care Association of Uganda, and Ministry of Health led the development of this important resource, but it majorly talks about making a will, succession, and rights of patients and families. Advanced care planning is yet to be addressed in some of these resources. And as I end, I want to read out this important case study of a 50-year-old gentleman who had end-stage liver failure. He had no opportunity to have advanced care planning. He was admitted in hospital towards the end of his life for further management and investigations. He was not happy with the idea and he discharged himself against medical advice. He decided to go home, but on arriving at home, he was forced into admission due to worsening symptoms. And soon he was moved to intensive care unit against his will. And he never informed close family members beyond his wife. And he died a few days later. He left no will, but the siblings were hurt because they believed he was not given a chance to live. And his mother has had to live with a prolonged grief disorder because he knew nothing about what was happening to his son. And he was shocked to hear the news of his death. And the family has not had a closure since. They continue to live in severe distress. Could he have benefited from advanced care planning? That's a question I leave for you. And I have some references for you here. These slides will be shared with everyone. And now I want to turn it over to Dr. Nahla Jaffer to share with us some experiences from Sudan and WHO EMRO. Over to you, Dr. Nahla.
Thank you so much, Eve. It was a very nice presentation. You went through the wonderful review of the literature and showed us how Uganda can lead Africa in advanced care planning. I want to share my screen. Okay. So I will start about the situation. And there was no possibilities of resuscitation. So what happened is really smooth, were bored, and we were speaking to the family, patients peacefully, hospital, and there was no, but now the bopping, a lot of ICU units. It really speak about recently I was in a and they told a story about a child in the and this child is advanced stage, and the family knew that with the family and told them reached an advanced stage, and there is further doctors treatment. Unfortunately, what happened is that as the child died, the family sued the doctor through the court. The doctor's hospital brought all the evidence that they cared for the child till the end, and said the doctor's not guilty. But what happened is also after this decision from the court, the family of the child sent a message, because they are a strong tribal, And they said to the doctor's family that you have to pay for us because you terminated the treatment for our child. And this is one of the problems that doctors are going to face if there's nothing documented. And Dr. Eve mentioned informed decision. How can we have informed decision without this communication, the patient knowing about their diagnosis, the patient knowing about their prognosis, okay? And also the patient, since the start of their management or since the deterioration of their situation, they are the people who are choosing what the care that they would like to receive. Here, this is my colleague, Mahasin. She's a trained palliative care nurse. And here she's with one of the patients who's still alive and doing well. But I would like to speak about how Mahasin, with her training in palliative care, helped other patients through this difficult part. Mahasin intervened in the case of a patient with advanced cervical cancer. And this lady was coming from a very far area in Sudan, in the village in the Darfur area. And Mahasin was telling her about her situation and about how her disease is advanced, no further treatment, and gave her an insight about what is expected to happen to her. And it was the decision of the patient to go back to her village. She said, I want to go back. I want to sit under the tree in my house. I want to enjoy the very nice breeze that comes when we spread the water in the courtyard. And this happened. And Mahasin had a telephone call with the patient, and she told her, I arrived there. And then after, I think, 2 weeks, the patient died peacefully, surrounded with her children. Another case happened to me, and I went to see a young lady with colorectal cancer, very advanced. And when I went to her house, so they told me that she is advanced stage, but I was shocked by how she was. She was almost like skin on bone, very thin, very emaciated. And she was there, her sister was there, her brother, her husband. So I sat with them, and of course I couldn't say that she's actively dying because she wasn't at that moment also, but I gave them a glimpse that she's very advanced. And I think after a week or 2 weeks from that, they called me and they told me, we are now in the hospital because she became unstable. And in the hospital, they want to send us to the ICU. And I mentioned to them, okay, I need to speak with you. So on the phone, I spoke with 3 of the family members, went back to revising for them what would be her wishes and what is expected after her reaching this stage of her disease. And they agreed to me that there is no need for the ICU, especially looking at the enormous huge costs of ICU. It's like the cost of buying a car for 3 days or 4 days. It's like as if the price of a car. And that was their decision. They told me, no. They told the doctor, no, we are heading home. We are not. And they went home, and I was following them by phone, and she died peacefully at home after 3 days. In Saudi Arabia, and this fatwa, which is called, it's a binding religious opinion, it is very useful in Islamic countries because we can also adopt it. They have this nice religious opinion after a lot of studies and scholars, religious scholars also with doctors, consultation with doctors and palliative care specialists, they come up with this fatwa about DNR, in which they say that if there are 3 licensed physicians separately, and each one said that this patient, any further life support would be futile, they can terminate the management of the patient. And this is very useful, especially in countries where you have all the facilities and ICU is not like a problem. So patients can be staying in the ICU for 3 and 4 months or 5 months or even years. So my main recommendations are the widespread training in palliative care, because without training in palliative care, you cannot reach the point of discussing with the patient while the patient is still fit and alive and speaking about the prognosis, okay? We need to provide palliative care, especially in the home setting. So what is the benefit? Yes, we can have advanced care planning, but if we have advanced care planning and patient says, I don't want to have life support, but also if we have home care, that would be the best option for patients. So we need to train people in palliative care, and we need to spread home palliative care. And of course, involvement of the patient and the family in the advanced care planning, because the family is going to support you, okay? And of course, having the legal and protective. Thank you for your attention. So legal, yes, protective legal framework. And here I put some further readings to be added to Dr. Yves. And thank you for your attention.
Dr. Nahla, thank you very much for your excellent presentation and the excellent work you do around the world.
Thank you.
I'm now going to invite our next panelist, Dr. Lane. You're welcome.
Thank you, Eve, Nyala. It's good to sit on this panel with you guys and be here and have the opportunity to represent Mozambique. I have been here for coming on 15 years, working exclusively with the oncology department, but my husband and I run a small palliative care and hospice home supporting oncology patients that come from the provinces. And so I was asked to share some stories from my experience here. And when I was thinking about it, I decided to share with you a story of a recent patient that I think holds within it 1,000 stories, as I find this story repeated over and over. So a patient came to us. She was a single widowed mother of 3 teenage children. She was transferred from a province that was about 23 hours away by bus to the capital city where chemotherapy and radiation would be available. She presented with advanced cervical cancer and hemorrhage. She was given a single high dose of radiation and then started on 6 cycles of chemotherapy, followed by a prescripted 30 days of radiation with the understanding that cure was not the goal. The radiation machine broke. We have 1 radiation machine in country, and it broke at day 25 of radiation. And due to a delay in repairs, the patient was sent home, and no CT scan was given to measure the progress. The patient felt better and went home hoping for a miraculous cure. After 6 months, the patient returned to us for her checkup, for her control, and she had a nagging, persistent cough and some rib pain, despite some antibiotics she had been given by a general practitioner at home, as well as some lower back pain. An X-ray showed a suspicious couple spots on a lung, and a CT was ordered. So while we were waiting for the report from the CT, the patient's back pain escalated to the point that we ended up in the emergency room with the patient screaming. She could barely walk. She moaned with any movement. The CT results came out and it showed a probable metastasis on her liver, her lungs, and her spine. Morphine was started along with a one-time dose of zoldronic acid. And while the pain wasn't eliminated, it was improved. At least she could walk around. So here's where advanced care planning matters. The options this patient had with her recurrent cancer. The health team looked at the disease and they believed that chemotherapy could potentially reduce the metastasis on her liver and in her lungs. And maybe it could extend her life some months, maybe reduce her pain. So the team wanted to encourage chemotherapy. The problem with that was that per protocol, the metastasis had to be confirmed as cancerous before the start of chemotherapy. That meant a liver ultrasound and a lung biopsy. Well, we work in a very overloaded system, and we knew that it would be weeks before the procedures could happen, and then it would be more weeks until the results could actually become available. All the while, the cancer would be growing. Remember, this lady is 23 hours by bus from her home and her 3 children, who are her whole reason for existence. This was the moment that we needed to know what was important to her. She needed to know the reality of her situation in order to make a clear decision. Well, because she was living with us, we had the time. We had the time for many emotional and honest conversations. The patient decided herself that she wanted to go home right away, and she wanted pain management. So we arranged quickly for a final consult for her to get her discharge papers. My husband's a thanatologist, and before going into the consult, he had a conversation with a few of the doctors. And they agreed, after they had some more information about the invasive lung biopsy that was necessary, that indeed she should go home. Everybody was in agreement. The patient wanted to go home. My husband and I agreed it was time to go home, and the doctors agreed it was time to go home. Fast forward to the consult. When they sat down, the doctor, instead of asking how the patient, how she was feeling, what she was thinking, or what she wanted, went on to present all of the treatment options again. Instead, she did this, making them look burdensome and put them in a dim light, hoping that this was communicating that she wasn't recommending treatment, but she was unwilling to be direct. The patient ended up feeling like the doctor actually wanted her to stay and do treatment. And she was about to reluctantly agree when thankfully the doctor's phone rang and she stepped out the room. The patient looked helplessly at my husband, and he reassured her that the doctor was actually attempting to tell her that she should go home. And he asked her again, "What do you really want?" She wanted to go home. So the doctor came back and they told her that she wanted to go home. Everyone was relieved. Prescriptions were written, a plane ticket was bought, hugs were given, tears were shed, and she was sent home to the arms of her children. So what does that tell us about our current practice here in Mozambique? Mozambique is predominantly a paternalistic patient-physician relationship. So the doctor pretty much will tell the patient what's wrong and what they need to do. And the patients really expect that and almost want that. There's a lot of power dynamics at play. There's a lot of respect for the doctors, and patients really fear contradicting what the doctor wants. As we saw with my patient, when she felt like the doctor was recommending treatment, she was about to go back on what her priorities and her preferences were. patients rarely know that they actually have a voice or that they can make a different choice. Doctors are very focused on illness and cure. They feel like they're doing a good job when they offer anything and everything that they can. They rarely try to know the patient's priorities or preferences. Doctors rarely consider the cost-benefit ratio. They lack whole person consideration. So they're thinking about the illness. They're not thinking about the cost of treatment for the patient. Doctors are in desperate need of end-of-life communication training. They need to be able to state simple and clear facts. Doctors fear prognostication. They fear blame. Mozambique has no laws regarding end-of-life care, and so they fear that the patient will come back and accuse them of doing something wrong. Doctors fear telling a patient that they're dying. They fear taking away their final hope. One thing I can report on is that my husband is a thanatologist, as I said earlier, and a thanatologist is a specialist around end of life, around death, grief, counseling, and bereavement. And so he has begun thanatology consults in the oncology ward at the Central Hospital. And so doctors, when they are certain that a patient is terminal, actually refer the patients to my husband. They've been a positive addition, though doctors rarely are willing to prognosticate, as I said. And so because of this, they only are referred maybe when the patient has 3 to 7 days left of life. The surprising thing that we have seen is that instead of families and patients not being able to handle what's being said, especially when it's communicated directly, oftentimes they break down crying and thank my husband for saying it. And predominantly, the patients' families want to take them home. They want to take their loved ones home to die there, surrounded by their family. So we have a lot of challenges when we're thinking about advanced care planning here in Mozambique. One of the major issues we come up against is that our country does not have electronic medical records. So what's the solution? Can patients actually keep these documents on person? One thing we typically see in chronically ill people is that they tend to have a plastic file folder with all their medical documents inside. Could they place an advanced care plan in their document? Doctors would then need to be taught what advanced care planning is and that they need to respect what this form says. I know that an idea that we had was that our government buildings, anytime that there is a form that needs to be filled out, typically will post a template on the wall and patients will come in and copy it and fill it out. So perhaps we could do that with advanced care planning. Maybe we could put a form on the door and we could maybe have a doctor, a social worker, or a psychologist come in and give talks to the waiting rooms, educate the patients about what advanced care planning is, be there for questions. But it's difficult to decide who has the time for this kind of work. Like I said, the system is very overloaded. We need to think about who's the appropriate person to be having these conversations. Should it be social workers, psychologists? Should it be spiritual leaders? How can we build trust enough with our patients to have these conversations? It seems like in the medical consult, there's not actually the time to have these sensitive conversations because our doctors are overloaded and inundated with patients. And these conversations require time to be emotional, time to ask questions. And so that's something that's been beneficial about my husband, because that is all he offers in the ward. He has the time to spend 45 minutes with a family, 45 minutes with a patient. That's just not something that our doctors would be able to do. And then it's also difficult, education and language. Eve hit on this as one of the barriers. Mozambique has over 70 languages, and our patients that come from the provinces, it can be difficult to educate them on their illness and the options that they actually do have. And so again, this kind of communication takes a lot of time. You have to have very simple, very clear communication. And we really need to start thinking through who is the best person in the medical system that has the time for this sensitive work. Though we can see that advanced care planning is very important to our patients. We just have huge strides to go. Anyway, thank you for your time. Back to you,
Thank
Eve.
you very much, Lynn. That's impressive. We have Professor Anne Merriman online. Professor Merriman will give you an opportunity to unmute, talk to us a bit, and to share your experience. We'll give Professor Merriman a moment to prepare herself to unmute. I think it's an opportunity we can't miss. Anne, are you there? Yes, Anne, please unmute and say a word about this topic. Should I unmute her? Let's see. I think you're able to unmute. I will say Anne just shared with us an interesting experience that she has had her advanced care planning since 2017, and she has had 3 episodes where it needed to be used, and her wishes were respected in 2 hospitals in the UK and in 3 hospitals in Uganda. And Anne is the founder of the modern palliative care movement, actually in Africa. And she has practiced, and she has done this for the last 42 years. Yes. And actually, all of us, many of us know Professor Merriman, really. She's our Cicely Saunders. And she's attesting to this, that she has her advanced care planning, her advanced care directive, and it has been respected. And she has had 6 episodes, you can imagine. And then Anne raised the question here that we find that many people are advised by cultural beliefs that they die faster and sooner if they have made a will or advanced care plan. What do the panelists have to say about this? How should we overcome this? Nahala, do you want to start?
I would like to answer the question of Dr. Lynn about the challenges that we are facing with advanced care planning, and also it's also linked with what you mentioned now. I think that it's very important to have this relationship, the doctor or healthcare professional and patient relationship, long time ago, and not to have the palliative people who are trained in providing palliative care, people who are trained in good communication skills, to come at the last moment, because it will be very intrusive, especially for the family, because they see that they are like denied active treatment, and they are sent here by force to these people to speak with them and force them not to have active treatment. But when the relationship has been built up long time, it makes everything come very smoothly. And I have experienced that it is always the patient who are saying, no, I don't want further treatment. Because I'm an oncologist, I remember a lot of elderly men coming to me and their sons insisting that they continue on treatment. And they say, no, it's enough for me. I just want to go back. Please leave me. I don't want to go. especially if they're coming from a different city. So they want to go back and stay in that in their home, in their places, and enjoy what is left of life. And so this is my answer about the earlier involvement of palliative care teams and good communications.
Yeah. Okay, and I'll respond to Professor Merriman's question because I've been at the side beds of the dying and worked with bereaved caregivers for a long time. Definitely, the cultural beliefs are a big problem. And the way to go around this is to challenge these negative culture beliefs, the negative cultural, gender, and social norms, and to preach about the positives in this advanced care field. For example, I've given you an example of this patient who was being dragged to hospitals, to intensive care units, all against his will, who didn't have an opportunity to know that probably the end was coming and what were his priorities at the end. He left the mother devastated. He left the family divided. Probably he had information that he would have loved to pass on and also make decisions on how he wants to be cared for. We've seen people fighting over where the body should be laid to rest, and issues go to court and they spend a full month battling that out. We have seen people fight for bodies in hospitals. If you have 3 wives, everybody is claiming ownership. What if you were empowered before to tell the doctors that give my certificate to Alice, give my body to Alice? And maybe who do you want close to you at the end of life? Why should women or men come to fight close to your bed in this most difficult moment? Give your advanced care directive who should be close to you and who should critical information be shared with, or who should make decisions when you have lost the capacity. And I can say that culture is a big problem. Beliefs and values are a big problem, and we need to work with them in a positive way. Lei, do you want to add anything to that?
I think that also if we can introduce the idea of advanced care planning even before people are sick. So if we can encourage these conversations in middle-aged people who have yet to be diagnosed and get people thinking and making the conversation more normal, I think it can be beneficial, because when you are sick, there's so many emotions at play, and sometimes it's more difficult to make those calls. And so if you can think about these things earlier, so yeah, I think if we can even start introducing them in other ways in the communities and normalizing the conversation, I think that can overcome some of these ideas of that it's bringing death faster, because if you're not sick to begin with, an earlier conversation would be better.
Yes, and we can also use existing pathways to start this conversation, because advanced care planning is part of palliative care. And for example, making a will is biblical in my faith. So if making a will is biblical, why can't I have my advance directive? And Germans, you noted that we should talk about the barriers to implementation. I think Lei has discussed that. There are issues of education, there are issues of culture and values, there are issues around, you know, that delicate intersection between ethics, the law, and advanced care planning. And you don't want to get yourself onto the negative side. You don't want to overwhelm yourself. You're the clinician, you're doing the advanced care directives. Maybe you don't even have the skills, and then there are these legal issues. Do you wear all those hats? So at times that can also be a challenge. And Dr. Guma's paper explains all that in detail. And also the paper led by Diana Basilica and Professor Merriman also explains that in great detail.
I agree with you, Eve. Having the patients think about their will is a very nice way to carry along the advanced care planning. Okay, and it's very easy. Do you would like to prepare your things when you are not there? We know this disease is like having a bad prognosis. There is, I don't know, whatever chance of you dying from it early on, to have the patient think about their will. And unfortunately, when patients are admitted into ICU and families are sending their family members to the ICU, they have this wrong idea that we are going to ICU, we are getting out alive, but the mortality is almost 85%. And I think there is the ICU professionals, intensivists, doctors there should be trained in palliative care. And we have a very nice example in Sudan in which anesthesiologist in the ICU is trained in palliative care. And so he's consulting the families when they are bringing their patients and telling them about the prognosis. And so he's working against his counterproductive, but very good outcomes.
Yes, thank you.
And there is a question in the question and answer about when there is culture, religious dictates contradict ethical considerations, like the patient wants DNR, but the family refuses it. And I think it comes back to the starting point when we say it is the patient's right to know their diagnosis, to know their prognosis. But if you have the patient not knowing anything, how can you introduce a paper at the end and tell them, please sign here? It will never be accepted.
Professor
I feel
Musisi, kindly unmute and share with us. Professor Musisi is a professor of psychiatry, and I think it's important that he shares with us some of the lived experiences. Professor, are you able to unmute and share? He asked a question that what happens when culture and religious dictates or contradict our ethical considerations? Professor, please unmute.
I think he's having a hard time finding the unmute.
Can you hear me now?
Yes, we can hear you. Thank you.
Yeah, thank you very much for these very, very wonderful presentations. Dr. Nahla Gafta and Dr. Liane Heller. These are issues that we deal with, especially in developing countries, especially in Africa. The question which I asked you there is, we often encounter it, whereby families' beliefs, either cultural or religiously, contradict the patient's. And you have this dilemma of what to do. Sometimes the patient may want to do things that you consider almost immoral or unethical. I'll give you an example. A rich middle-aged man with terminal colorectal cancer was receiving chemotherapy. He refused chemotherapy, was convinced by some herbalists that the herbs are going to work, left the hospital, left the chemotherapy, took the herbalists, for whatever reason, felt very enthusiastic about himself and felt that he was really beating the disease. And he decided he had no son, so he decided to marry this young, kind of ignorant girl so that he can have a son before he dies. And the girl accepted, and he married her and gave her a car and business and stuff like that. And yet this man knew he was going to die, I think, because he was educated. But yet the relatives and himself said it was okay for him to marry this very young girl, leave her pregnant, and die. No amount of convincing could convince this girl not to go ahead with the marriage. They married anyway. He died in 3 months' time before she became pregnant. But suppose she had become pregnant. How do you deal with issues like that? Another one which I would like to discuss is the issue of mental illness, dementia, for example. When the patient cannot really make a decision because they're mentally incompetent to make that decision, but he may be, or she may be a matriarch, or he may be a patriarch, and everybody in the family is fearful of making decisions for that one, but he had no ACP, no advanced care plan. The question then is that, what do you do? And sometimes, what don't you do? Whatever you say, somehow the family may even threaten to sue you because they may think that you're doing things that, quote, are unmedical, although strictly speaking, they're very medical, like especially palliative care interventions and stuff like that. So these are some of the things that, to me, I thought would like to talk about. Any ideas? And I've seen all of those in my practice.
Thank you very much, Professor Musisi. I actually thought you would give us some ideas.
No, I wanted to present them
Yes.
because there are no written rules about this. Because most of the guidelines that we have, for example, the things you read from the Ministry of Health or the legal implications, are not written in the context of African cultural reality. There are guidelines that work very well in the West, but in Africa, there are things that go beyond that because of cultural dictates, because of reverence, for example, of the elderly or seniors, or the other one who talked about paternalism, the paternalistic attitude. You know, many times patients come to me and they want me to make the decision, and I tell them it is their decision. And they say, but what do you say? And I want them to make the decision. So these are dilemmas that I think we need to do some research about to know how to guide people. If people know way in advance that you've made these advanced care plans, and I've seen some of them, even people, the point of, you know, digging their graves or whatever it is, you know, where they're going to be buried. People think these are very awkward people.
Yes.
You know, they don't want to relate to that. So these are issues, you know, that to me, I think that we need a conversation about. Sometimes I say, maybe we should use Ubuntu philosophy to guide us. But we need, you know, things are changing, cultures are changing, life is changing, new realities are coming in. We need to make some decisions. Not to mention that family members always quarrel about these decisions. For example, go home and not the ICU, or not to go home. You find family members quarreling about this thing. And I think when you do palliative, you know, psychiatry, you find that these are issues that you have to deal with all the time. Whom do you respect?
Thank you very much, Professor Musisi. Anne?
Yes, I'm here now. Sorry about that.
Hi, Anne.
Yes, I agree with Professor Musisi there, because the elderly are increasing, but they're not increasing very fast. There's only just over 2% elderly in this country. In my country, where I was born, it's 20% elderly. People of over 100 are going out to do their shopping. They can more make their own decisions. But dementia is a different thing altogether, because unless they've made an advance directive before dementia comes on, it is a difficulty for families everywhere, I think. But I think Africa needs looking at, especially in this one. And I hope Professor Musisi will do some research into this, because it is really needed. And I'm sure he sees dementia coming on before old age as well. So,
yes.
You know, yeah. So this is, you know, this is something that we need to look at. But with my experiences, my friends came to me in UK and said, we think you need to make an advance directive. And I had made it about 3 years before I had my first contact with death in a hospital. And I just had surgery for cancer, and I got a heart attack straight afterwards. And I was sent to the coronary care unit. And my friend came in and said, I think we should put the advance directive into your case sheet. And I said, yeah, oh, good idea. And so he did. And then the next round was done by a different doctor. The ordinary doctor, the usual consultant, wasn't there. And this doctor had the little cap on. He was Jewish. And he went round to everybody. He came to me last and he drew the curtains around me. And I thought, oh my God, he's going to tell me I'm going to die or something. But anyway, he said, you've got an advance directive in your case sheet. And I said, yes. He said, you've got to be very careful. You at that stage, I was early 80s. He said, you've got a life to live and a life to do things for others. And he said, you know, if you get any kind of attack, the nurses will neglect you. They won't do anything to support you. So he said, for you, I said, he said, I would take that out, which I did. I didn't have any life-threatening after that one in that hospital. Yeah. But, you know, it made me realize that you have to think carefully about it and where you are, you know, at that point. The other life-threatening diseases were in 3 hospitals here, and those 3 hospitals all accepted. I have a doctor. I'm very old now, Nala. I'm very, very old. And many people think I should have popped my clogs before now, but I haven't done. And I do get ill quite often. And I have one in my advance directive. I do not want to go into hospital, but I do realize that I have to go in for fractures. Twice I've had to go into hospitals for fractures over this time. So you have to put in something like that, or you have sitting at home with your fracture, and you know it won't get better. You really need surgery at that point. But I had one experience that the doctor that comes to my house and sees me, I was in a hospital having my fractured femur sorted, operated, and the 4th morning I was there, I started getting breathless, and the doctors realized I was going into heart failure, and they got terrified because they didn't have a physician actually in that hospital. It was a specialist orthopedic hospital. So they said, oh, we'll have to get you to a physician straight away. So they put me in an ambulance and sent me to the hospital where this particular doctor happened to be. He came out and examined me in the ambulance and then arranged for me to go home with all that was needed, with the oxygen and with everything that was needed at home. And now I live in a house called Andrew Kagwa International Hospital, where hospice and palliative care nurses sleep in the room with me when I'm very sick. So, you know, it's because this doctor that looks after me had the advance directive. He knew I didn't want to go into hospital. And so he just came out to the ambulance and examined me there. And I was very moved by that. I thought that was such a good idea. So it's worthwhile getting it, you know, definitely for us in palliative care who recognize. And if you can tell a patient that you've got one, they think twice about saying no, I think. So that's my experiences. Okay.
Thank you very much, Professor Merriman. That is gold. Nahla, you had a comment?
Yes. I want to answer Dr. Musuki about when it is the family and the patient like choices are contradicting each other. I think the solution is to spend more time. I think my colleague Lane mentioned it, that it takes time to discuss and to sit with the patient alone, sit with the family members alone, and have this family meeting with all of them together. What is the goal? And if the patient is demented or unconscious, so we still have that discussion and we identify who is the nearest person to the patient and who knows what the patient's wishes would have been like. And this is, I think this is a big change in African culture about the patient is the one who chooses what happens, and also about thinking and speaking about death and not shying away from death. As mentioned in the beginning of the questions, you said that bringing advanced care planning is like inviting death. And so we need to speak more openly about death and prepare for it. Thank you.
Lane, do you have any comment?
I find the idea fascinating about just because I'm an American, I value individualism and I value patient rights. But after living in Mozambique for as long as I have, I've come to just really witness communal living, and I begin to be unsure in situations when the patient and the family might disagree what is right. And I think as Africans, it's important to think about what is the most right thing in that situation if we really are ascribing to something like Ubuntu, where I am because we are, and what benefits the community might be more important than what benefits the individual. And I haven't landed exactly here, and we've had some cases that are complicated, but I do think that this is one aspect of palliative care and advanced care planning that might be different from America or the West, and what is right and what is ethical in this culture and in this context.
So thank you. Tanja, do you want to say anything, unmute yourself and clarify on something important? Tanja Crowns. Okay, we can read his comment in there if we want a distinction between advanced directives and advanced care planning. And ACP is primarily for situations in which you're not able to communicate and you do not have to put that AD. You do not have to put that into an AD. Good. Oh, you're not able to unmute? And Kennedy Nkoma is asking whether Africans can participate in these conversations. Kennedy, I think we can participate in these conversations. all of these words can translate into our local languages, but confronting them requires courage, requires the spiritual and mental stability. And it requires time. And like Leigh said, who should actually be doing this? When you ask the clinicians, some of them complain that they are being dragged into so many things. And by the time they leave the clinic, they even have a headache. Professor Musisi, I don't know what your experience is. I know you've said you tell patients that it is them to make the decision. Have you ever been dragged into?
You hear me well?
Yes.
Yeah. Often families come when they're caught in a dilemma. I'll give you an example. A patient was in hospital, and I was consulted because they wanted to amputate his leg. And he said no. He was mentally competent. We do not think he understood the ramifications of his refusal to amputate a gangrenous, foot. And then his elder brother came, and they told him the dilemma. And the brother said, "No, amputate the leg." And the patient said, "Well, if my brother says so, amputate the leg." So you have to understand the cultural nuance of decision making. Like Lane said, in Africa, our lives don't just belong to us. They also belong to the others, and others have a say in them. And oftentimes we listen to them. But then a cultural clash may sometimes come, actually a religious clash. I had another patient who was 2 years old. She was very severely anemic. And the parents said no blood transfusion. because of their religious dictates. Well, they brought up the Hospital Act and he said, no, it is not you to make the decision. The Hospital Act is going to guide us to make a decision to transfuse this 2-year-old child. The child was transfused and lived, but the parents had refused. So we need all kinds of guidances, both legal, ethical, but also cultural, before we put down what the final law is. But the debate will continue. And I would like to assure, not warn, but just assure practitioners that you will end up in court somewhere. I have, whereby these things have clashed, and you get accused of doing things that you think are very ethical, but which others don't think very ethical. I'm a psychiatrist. Many times you diagnose a mental illness and somebody says, I don't have a mental illness. And even the family members, some of them may say you don't have a mental illness. Yet you know that there is a mental illness. And somebody is making a decision in accordance with the mental affliction. And you say it cannot be because they're mentally ill. And you end up in court. So, these things are there. In fact, I'm glad Dr. Merriman mentioned it. That we are seeing dementia in younger and younger people, And this dilemma is coming. They say, no, this person is not old. He's 60 years old. His mother is still alive. She's 80. She's perfectly okay. How can you say he's demented? Yet he is. So these are issues to which we have to make some guidance. But like we said, we should do some research to get some guidelines. And I would like to call everybody on board so that we join into this new practice of medicine. And I cannot overthank Dr. Merriman for having opened up our eyes to all of these things for the continent. And because these are issues that come in palliative medicine all the time. And they go in all disciplines, whether you're in pediatrics or in geriatrics, in obstetrics or in surgery. She just told you about her experience. So yes, we need to do something. We need to confront these things with knowledge, but with cultural understanding and context. Yes.
Thank you, Professor.
Those are my final words.
Tanja, over to you. Tanja?
Yeah. I would first really like to thank you, Evelyn and Nala, for this absolutely excellent talk, excellent organization using AI for the chat. I'm really impressed of this excellent seminar. I'm Tanya, I'm the head of Advanced Care Planning International, and I was so happy that you agreed to give this webinar with a lot of absolutely important and nice issues. What I can really say, if you read the CEFCO journal, you have just mentioned, and with the excellent articles, you will see that we all around the world have the same cultural issues. It's not that we are individualistic here in Europe or the US only. We also think about the families. We know we care about the families. So it's really a stereotype, and we can so much learn also from this relationship. I mean, we have in ethics the relational autonomy, right? This is a concept that is very important. And so we also care about the families. It's not like, this kind of huge divide, I would say. And also spirituality and religious issues, of course, are hugely important when we deal with the issues. What I was just putting in the chat is one thing that we have got good research in recent years on pediatric advanced care planning, really including children and facilitating also talks between parents and children when they're sick and they're a little bit older. We can really try to help the family to heal and also go palliative ways sometimes when it's needed. So there is some research and happy to share. And it would be lovely to share among pediatricians. And the one thing I would say, what you mentioned with the hip fracture, it is really a typical thing that we sometimes mix, that we think we have to put things into advanced directives and goal of care plans when for situations where we are capable of decision making. I mean, if you break a hip, you are normally able to talk. right? So it's not, you know, having this and this and that. Is only for having really clearly situations in an emergency where you can't talk, but the goal of care is maximum life-prolonging treatment, or foregoing some because you talked about it, or really doing best palliative care in an emergency. And it might also be that for people who are really say, you know, it's not important for me to live until tomorrow, and you have the opportunity, which is a huge problem, not only in many countries, that you can do, for example, palliative sedation at home, you can also treat a hip fracture palliatively. If you say, my goal of care is not, you know, I want to, you nicely showed that, Nala, I want to be at my home, and we can provide excellent maximum palliative care, and you have an emergency advanced care plan saying, in any emergency, regardless of what would be, I want to have a palliative care plan, you can treat a hip fracture also at home. So this is a very different kind of development during the last, I would say, 10 years, going more this way. Yeah, but thanks again for this excellent, lovely introduction to your views.
Thank you.
superb.
Thank you. And we thank Advanced Care Planning International for helping us to start this conversation in Africa. And we can see the need is huge and massive. And we need to act as soon as possible, else we may find ourselves in trouble, whether at health system level, patient level, family level, or community level. Nahala, you had a last comment?
Yes, I wanted to mention a story similar to that of the boy who refused, who didn't want the amputation, and then his brother interfered. So in Sudan, giving young women chemotherapy, and sometimes I'm faced with this lady who says, "No, I don't want to take chemotherapy. No, I don't want to do the surgery." And we know it's like life-saving for her. Good prognosis, breast cancer. So what happens is that after discussing with them and telling them everything, this informed consent is very important. Then we write in Arabic that the patient was told about her disease and the management, and she chose out of her own will voluntarily not to take active treatment, and she signs. Then we learn something else. If I ask her to bring a caregiver to sign also, what happens? The caregivers, like the brother or the husband, will say, no, that is better for her. No, the decision is to take the treatment. And so this involvement of the family in Africa, I think we have to make benefit of it and to empower the family, to teach them more about the prognosis, and to make them help the patient to have the correct decision.
True. So power dynamics is important, and
Yes.
being able to tease out who are the decision makers. Should
And
be
also
in
it will
our,
protect us. If we involve the family early on, we are protected. So
yeah.
nobody's going to take you to court.
Yeah.
Depending, okay. So we have just about 3 minutes. I'll see if we have any questions. I see examples here of public campaigns together with artists and community champions. These have been used in New Zealand, Singapore, and Spain. Is that so? Okay.
Yeah, just to give some examples. So they're really excellent community engagement policies, and New Zealand has started very early on with public patient involvement coming also from the Maori population, so the First Nations. And they're very successful in having this grassroots ACP development in the country. Also, Singapore has merged with artists, with champions, like known people from the community that are very much valued, who say it's so, you know, these are so important conversations. They are lovely conversations, and they tie together families. So it's a really different framing. They have national conversation days, national conversation weeks, where, you know, media are doing it, and promotes, and television promotes stories about, you know, usefulness of talking in families about what is important people, what should not happen to persons. And this is what it is about in the first place. And yeah, just to give some examples, when you look that up, it's really, really nice. They just had in Barcelona, where the European Association for Palliative Care was having their research conference, and they had a great campaign funded also by many, many institutions in Barcelona about, talk about death, and a lot of people came, and yeah, so it is great to go together with artists and community champions to promote advanced care planning issues, because it's about person-centered care. It was about. It's about person-centered care.
Yeah, thank you. And Edna says medical people are trained on hard language, and so they have difficulty in learning effective communication, and says the Bible and Quran teach about advanced care, and some religious education is against such. So I think there are some entry points in the Bible and Quran to help us start these conversations. And where they don't exist, look for opportunities. We have the Safari Concept book by Christian. I don't know if, Carla, you want to say something about that? Carla?
Can you hear me?
Yes.
Yes.
Yeah, he wrote a book based out of his experience in Rwanda, and it goes through, he uses different, almost contextually in Africa, animals to discuss the power play in the family dynamic. So it really helps you understand culturally the person in the family that's really that power person that you want to approach in the discussion. And I thought it was very, very culturally appropriate. Even I'm American, but I feel even in America, I could identify psychologically who he was talking about. So for me, it brought the cultures together in just a different contextual way. Because like somebody was saying, even in America, I've done palliative care now over 20 years. There's still a lot of family involvement, communal involvement, especially with our immigrants and refugees. So I think that book is worth somebody reading, and if you've done palliative care and communication a long time, you can identify with what he's saying. But I think it kind of breaks that dynamic of it's only in Africa. Africans are treated this way, and Westerners are treated this way. And really the world we live in now, it's so cross-cultural. Even in Mozambique, we have Pakistanis, Bangladeshis, Europeans we take care of. So I would recommend that book for whoever has time to read it.
Thank you. Let's have final comments from Professor Musisi, and then I think we would plan to have another webinar to take it on from here.
No, I really would like to thank everyone for attending. It's been very educational. It has been very opening for all of us, and especially for those who are on the African continent, to realize that these concepts of SCP or advanced care planning are not alien to us. We had ways of doing these things, some of which we have forgotten, but we also have to learn from other cultures, as indeed the last speaker said. The world is now intertwined. People live in very many different situations, living where they were not born. For example, right now I'm talking from Toronto.
Oh.
And yet last week I was talking from Kampala. So the world is like that. And the other week I was in Cape Town talking about these things. So the things that the world is now very much intertwined. And as the last speaker said, we have some universal concepts because human beings are human beings. And we should try to emulate the best in us and have the best palliative care for all. Thank you.
Thank you very much, Professor Musisi. And this is Christian's book. It's available via Amazon. If you need to take a look at it, please do. And Christian is a known physician, a colleague who is based in Rwanda. I think I want to proudly thank all the panelists. I want to thank Advanced Care Planning International, and then Professor Anne Merriman and Professor Segane Musisi for sharing with us all those important comments and experiences from your many years of practice. I want to wish everybody a wonderful rest of the day. You're going to receive the slides and the recording via the emails you used during your registration, and Advanced Care Planning International will also disseminate the slides and the recording. Thank you, and God bless you. Go forward to do better care.
Thank you.
Thanks.
Bye.
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 Bye-bye.
Thank you very much, Nahala. Thank you very much, Lane. This was a good webinar.
Thank you. It was great.
Yeah.
Thanks
Such a
lot.
pleasure.
Lane, you haven't been in Maryland?
I've not been to Maryland. It's all online. So I hope
Oh,
when I graduate, I'll get to go and walk the
okay.
stage. Yeah.
Okay, great. Okay, goodbye. Thank you all.
Goodbye.
Bye.